time for DocTalk Radio, brought to you by Gilbert Hospital in Florence and Anthem Hospitals. I'm Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio, sponsored by Gilbert Hospital and Florence Hospital at Anthem. Joe, it's good to be back in the studio this week.
Oh, absolutely. It was a great show last week, though.
You know, it really was. We had, for those of you listening, we had a live show actually broadcasted at Anthem, Merrill Ranch at Anthem. It was a beautiful senior community center over by the hospital. And I just thought it was a great venue. We're going to be back out there at the end of February as well.
Yes, looking forward to it.
You know, I want to just kind of get started here. We have a lot to talk about today. In fact, we have a guest in the studio that we'll be introducing in just a little bit, but I want to really kind of use the first half of the show today to really open up again the phones to people to call in, ask questions. There's some things that I want to catch up on. The number is 480-745-1033. Joe, you know what? I've had several patients this past, couple weeks actually coming in to the hospital with strokes, and I want to talk a little bit about stroke because there's different types of stroke. There's the TIA, there's something that we call the rind, and just want to kind of open up talking a little bit about strokes and some new studies out in reference to strokes and who's at high risk for strokes. In fact, there was a new study that just came out showing that middle-aged people who smoke pot actually have a 2 to 3 times higher incidence of stroke compared to those that don't. And, you know, we've talked about, I know you have the marijuana show, you know, and so forth, but clearly smoking of any kind increases the risk for stroke significantly.
So is it the marijuana, you think, or is it just the carcinogens in the smoke?
Well, I mean, I think it's probably both. You know, we definitely know that, you know, molecularly speaking, from the marijuana standpoint, the cannabis has the effect on the body where it causes vasoconstriction. And, you know, vasoconstriction means decreased blood flow, and that can translate into irritability, you know, within the blood vessels that feed the brain. And sometimes when you have vasospastic, you know, situations within the body and the vessels and the vasculature, it can cause little blood clots to form and flick off. There's 2 types of stroke. Let's just kind of start there. There's what we call the dry stroke and the wet stroke. A wet stroke is really considered more of a bleeding in the brain. You know, people who are on blood thinners, for example, that, you know, that may end up developing bleeding internally in the brain that causes damage and affects the brain tissue is called a cerebral bleed. That is a type of a stroke. Not as common. The more common type of stroke than when we talk about strokes is really more the embolic, what we call the thromboembolic or the dry type of stroke, which is caused by a little blood clot that is in the body, comes from either the heart, the lung, the circulatory system, flicks off, goes up into the brain, and it causes literally like a heart attack of the brain. And when you think about the blood flow to the heart, whenever a heart attack occurs, it's when the blood flow is blocked by a clot, and you get decreased blood flow to the muscle of the heart. That's what a heart attack is. Same thing in the brain. When you have decreased blood flow caused by a stroke or caused by a clot feeding the brain, that's a stroke.
Are strokes generally caused by a head injury or?
No, actually no. It's really more has to do with the vasculature, the circulation, the circulatory core. You know, atherosclerosis. People who have atherosclerosis have a higher incidence or a risk for stroke. People who smoke, diabetics who have, you know, hardening of the arteries, there's a higher risk of stroke. That's why it's so important to keep, you know, diabetic blood sugars under control because of that risk. And so that's kind of, you know, it's important to know. Now, people talk about TIAs, or you've heard the word TIA. It's a transient ischemic attack. And, you know, it's interesting how the body is really an amazing machine where sometimes we can develop little blood clots that circulate in the body, and it flicks off, it can go into the brain, and it can cause a transient mimicking of a stroke symptom where people can actually lose the ability to talk, or, you know, the clumsiness of the right side of their body, or the inability to balance and for whatever reason. And then within 15 or 20 minutes, that speaking of inability comes back, the symptoms resolve. That's called a TIA. It's a transient ischemic, meaning that there's decreased blood flow for whatever reason, attack. People who have TIAs, basically, it does not necessarily mean that they're at a higher risk for developing, a massive stroke, but we treat TIAs in a way that we want to prevent further TIAs or further stroke symptoms from occurring, and aspirin is really the recommended treatment.
Because, once they have a TIA, they're more, they're more susceptible to getting more of those, is that correct?
Can be, and the treatment is really an aspirin a day. That's what really has been found medically, from a research standpoint. It is the standard of care to use an aspirin to help keep, the blood thin, if you will. There are other things, people that are allergic to aspirin, for example, we can use Plavix, and there are different Agronox and different other medication type. Persantine is another medication that can help to really keep the blood thin. It's an antiplatelet effect, actually, because in the blood, platelets are really there to cause blood clots so that we don't bleed to death. And so we use medications like aspirin, like Plavix, like Persantine, that are antiplatelet type medications that really help to keep the blood circulating so that it doesn't cause little blood clots. And that's really what a TIA is. There's another class that we call a rind, which is a TIA that lasts for 24 hours. And the treatment is exactly the same. It just lasts a little bit longer. Usually a TIA resolves within an hour or so. If it lasts up to 24 hours and then resolves, it's more of a recurrent kind of neurologic deficit that, again, is treated with an aspirin or an antiplatelet type medication.
And Meredith from Mesa that called in wants to know, and this is a great question, why doesn't everyone just take an aspirin?
And that's a great question. The problem is that there's a risk-benefit ratio. Aspirin does not have, it's not 100% safe. It can cause GI problems like, for example, gastritis, people who are at risk for peptic ulcer disease. It can actually bring on and cause bleeding, and ulcers. So you've got to be very, very careful not to just use an aspirin when it's not really indicated, because you can actually exacerbate other underlying conditions. Now, there's a school of thought that I have to be honest, that's out there in the medical community today who say, aspirin has been found to be so beneficial that they recommend maybe taking it every other day or 3 times a week, even if you don't have the symptoms. And that's, that's something that some people consider doing. But from a medical standpoint, in terms of the literature and research, that has not been found to be beneficial in terms of, possibly causing outcomes that may not be good in terms of causing bleeding, nosebleeds, GI bleeds, those kinds of things. People who have low platelets, for example. And sometimes you don't know if your platelets are low unless you're, plugged into your primary care doc and being seen. If you just take an aspirin, just to take an aspirin, and you have low platelets, you can actually increase the risk of bleeding and, can cause internal bleeding, GI bleeds, and those kinds of things. So you've got to be fairly careful with that.
Frank from Florence called in and wants to know, what are the symptoms of meningitis? He says, I got the shot because it was available, and now my back hurts, and I have a headache. This has been 4 days.
Okay. All right. The shot itself let's just kind of talk about that. It protects you against a specific bacteria that can cause meningitis, and usually it's called the cryptococcal meningitis vaccine. Meningitis more commonly is caused by a virus. And if we're just going to talk about meningitis in general, the symptoms, the signs of meningitis would be a very stiff neck. And one of the assessments that we do when we assess somebody and want to find out if they have some of the signs would be if you try to put your chin down to your chest, and if you feel like you can't do that, or the back of your neck is just very, very, very stiff, an acute onset, meaning that you don't have a chronic neck problem of arthritis. It just kind of comes on suddenly, associated with fevers, chills, achiness, those kinds of things. That would be suggestive of the possibility of meningitis. Now, viral meningitis is something that is more common than people think. Usually it's self-limited, in fact, meaning that no matter what we do, it's going to get better. It's a virus that gets into the body, and usually we're used to an upper respiratory infection or a stomach virus. Well, in this case, sometimes the virus gets into the circulation or the fluid that bathes the brain. It's called the cerebral spinal fluid. It's the CSF. And usually it gets better, and because if you get spinal meningitis with a virus, it doesn't necessarily mean that you're going to get meningitis in the future.
Doesn't mean you're going to die.
It does not. It is a very self-limiting, disease. Now, on the other hand, people who have a bacterial meningitis, where it is a defined, definite pathogen that we see. Spinal tap is done. We get the fluid. We look at it under the microscope, and lo and behold, there's a bacteria, staph, strep, Haemophilus influenza, which is actually a virus, or actually a bacteria, the Cryptococcus. Those types of bacteria can be very, very fatal and possibly even life-threatening. So we want to make sure that those people get treated with intravenous antibiotics, usually for 6 weeks and if not longer. So it's really a drawn-out process when you're diagnosed with bacterial-type meningitis. The shot should not cause meningitis. It's intended to protect you. Now, yeah, you can probably have little achiness, kind of a little headache, and just not feeling well, malaise, maybe low-grade fever. What that is your body's immune system responding to the injection, responding to the vaccine, where your body is developing antibodies against that antigen, so that if you do come in contact with the cryptococcal bacteria, your body will be ready to fight it off. That's the same basis for the flu shot. We get a flu shot. It is not a live virus. It's a dead virus. So people who say, well, the flu shot gives me the flu, well, that's impossible. It does not give the flu. People can develop a reaction to the injection. You can develop low-grade fever, and what that is your immune system is just being boosted. It's the immune system response in response to the injection, and it's doing its job. It's basically developing antibodies so that if you come in contact with that particular virus, you'll be able to fight it off.
We had a question regarding the aspirin, a baby aspirin or a full aspirin.
Okay, great question. A baby aspirin, for those of you listening, is 81 milligrams. And for somebody that is diagnosed with, let's say, the first-time TIA, a baby aspirin is all that is necessary. Studies show that that's really all that you need to gain the protective effect of the aspirin without having the risk and the side effect of bleeding. It's not until somebody fails that baby aspirin for whatever reason, we go to a full aspirin, or if somebody actually has an acute stroke, depending on the area of the stroke, depending on their other history. If the stroke comes from a blood clot in the heart, for example, or if there's blockages in the coronary in the carotid artery, those are other reasons why we would recommend a higher dose of aspirin. So when we recommend higher doses is because there's other things going on in the body that warrant that higher dose. But let's say everything being equal, there's no source of it, there's no blockage in the carotid artery, the heart is normal, everything else is normal. A baby aspirin is really all that is needed to be prophylactic and preventative for strokes in that particular situation. Same for the heart. It's the exact same situation from a coronary artery standpoint.
Matt from Queens, New York says, I weigh 325. Should I take 2 or 3 because of my body weight?
Okay. It is not weight-based. And that's a very, very interesting, and it's a very good question. An aspirin, when we prescribe an aspirin, we don't prescribe it weight-based. So usually my rule of thumb, however, is anybody that has a BMI, a body mass index of greater than 35, which puts them in the category of morbid obesity, I would tend to recommend 1 full aspirin as opposed to a baby aspirin. And that's just simply practice preference. You may find some research and literature showing that really that's not necessary. A baby aspirin is probably all that you need. But the answer to that is absolutely not. More is not always better. And so in this particular case, more is not better. Now, there are some medications that are weight-based. For example, when we talk about blood thinners, Lovenox is a medication that we oftentimes use when somebody's diagnosed with a blood clot in the lung called a pulmonary embolism, or a blood clot in the leg. And we treat with something called Lovenox, which is a heparin that dissolves blood clots. Heparin, and particularly Lovenox, is weight-based. So depending on the person's weight is how we dose that medication. That's not the case for aspirin or Plavix. So that's just very, very important to know. I can't tell you how many times I've had people admitted into the hospital with either GI bleeds, ulcers in the stomach and the duodenum, in the GI tract, bleeding from an aspirin, from people taking Alka-Seltzer. We don't realize that aspirin is an Alka-Seltzer. And so during the flu season, You know, we have people who are already on an aspirin. Maybe they're taking Motrin on top of it because of the achiness, and then on top of that, they're taking maybe 2 or 3, glasses of Alka-Seltzer to help with the symptoms. All of that put together,
and then a shot of NyQuil before they go to bed.
And that's salicylate, and we know that that's very toxic and can be very caustic to the lining of the stomach, and it can bring on ulcers, and we've had people come in with just massive bleeding from
and
the
with
stomach.
a cocktail, that probably wouldn't help either, would it?
Yeah, that's not good. It increases acid production. I'll talk in a minute about what other things increase the acid production in the stomach, because those are things that need to be avoided, in people that have the risk of peptic ulcer disease. If you're started on an aspirin, things that you should maybe be considered and concerned about. But you have a question, John.
Susan from Tampa, Florida would like to know, she takes flaxseed to help prevent heart attack and stroke. Is that
flaxseed
valid?
is great. Absolutely. It's very good. Now, you're probably not going to find a mainstream medical physician practicing in medicine today in the hospital who would recommend that as a only treatment. For example, if somebody comes in is diagnosed with a TIA, flaxseed in and of itself is not the only recommended treatment. It's a great adjunctive treatment. It's a great integrative type of a modality.
What does it do?
It's an it has antitoxin, antioxidant type effects, and so in the body there are radicals. There are oxygen. It's a scavenger. It scavenges these oxygen radicals that circulate in the body, and for whatever reason, there's some increased risk of coronary artery disease, even some cancers when we're exposed to, these exposures in the atmosphere. Cigarette smoke is one of them that causes these radicals to be circulating in the body. If you cook something on the grill and it's very well cooked, for example, the charcoal has carcinogen effect in the body, and so we know that fresh fruits and fresh vegetables scavenge those radicals in the body. That's what they're called. They're molecular radicals.
So I have to jump in here and ask, because I like things very well done. Are you saying then it's better to eat things on the rare side than it is on the well done side?
No, I'm not saying that at all. It has nothing to do with rare or well cooked.
It's the charcoal type.
It has to do with the charcoal.
You make a hot dog and it's black, you're getting some radicals.
I've had patients, and there's actually a friend of a colleague of mine that we were just talking about not long ago in the hospital, whose family member actually was diagnosed with stomach cancer. And in looking back through the history, consistently this person would eat meat consistently. And the meat that he ate was always not only well cooked, but was burnt. And toast was burnt. So we were talking about that.
Even toast
as a risk
applies to that.
Anything that is charcoal that is black, that you ingest in the body, has the potential to have that carcinogen effect in the body. And so we were talking about, why would this guy who's otherwise healthy develop stomach cancer? And that was one of the risk factors that that we were able to come up with, and really validated it with some of the GI specialists and the oncologist that was taking care of them. So be careful. It has nothing to do with raw or cooked. It really just has to do with eating something that is not intended to be eaten, and that's just the charcoal, very, very carcinogen. While we're talking about that, I just want to talk about one other study that recently came out. Breast cancer is, something that we've had and talked about on the show many times, and postmenopausal hot flashes. A lot of times people go through menopause and they develop hot flashes, and the vasomotor symptoms along with hot flashes can be, very, very bad. Where it's almost like you can't function normal in the day. There are certain foods that have been recommended to kind of help with the hot flashes. For example, soy. But what I want to really kind of get and make sure that our listeners know is that soy contains plant estrogens. And so if anybody who, is on tamoxifen or who has ever been diagnosed with breast cancer or who has a family history of breast cancer, you really want to limit the amount of estrogen that you're exposed to. And there are 3 things that I want to just kind of put out there that I think foods should be avoided by anybody who has a risk of breast cancer or who has had breast cancer. First is soy. Soy is something that really should be avoided, even though it does help with hot flashes. So people say that soy is something very good for hot flashes, but you don't want to increase that exposure to estrogen, because then that could actually be a risk for breast cancer in and of itself. So soy should be avoided. There's something called black cohosh, which is an herbal preparation. Again, it has plant estrogens, and it should be something that is avoided, as well as red clover, which is a legume. It's kind of like it's a bean. And it has, again, natural occurring estrogens in it. And so those three things, if anybody who is on tamoxifen, has a history of breast cancer, a risk of family history, really shouldn't, eat those types of foods because of the exposure to estrogen. Do you have a question, Joe?
Jeffrey from Phoenix says, I'm 63 and I've been eating rare meat since I was young. Is it different now than it was when he was young? Is it dangerous now compared to before?
That's a good question, and I really, really don't know. I know that the FDA, we hope that the meat that we buy is safe. I personally am not an advocate of red meat at all. I don't think that it is very healthy for the body. We know that there's some studies out showing that increased red meat actually weakens the lining of the colon, and people who have a risk or diverticulosis, it can actually exacerbate and make diverticulosis worse. So it's not really good for the colon. There's an increased risk of colon cancer in people who ingest red meats. We know that there's an increased risk of heart disease in people who eat red meat.
It takes a very long time to process it through your system too, doesn't it?
It does. So, but in terms of the safetiness of it, now versus then, I really don't know. I do know that there's more chemicals in the atmosphere. There's more chemicals in the environment. Does that have anything to do with it? I personally think it does, and I'm sure that there's some studies out there, but right now I don't have that information.
But if you had, if that meat had a coli or mad cow or something else, if you cooked it good, wouldn't that cook it out a little bit?
It should. That's why you've got to be careful with rare.
Right. This day and age, it's a scary thought. Even eggs.
It is. There's something called E. coli. And it's a type of strain, it's a bacterial strain, E. coli 0157, and it causes hemorrhagic, problems in the body. And people come in with just a massive GI bleeding, acute kidney failure. I've actually had a person die from food poisoning from the E. coli 0157 bacteria. So that's very, very dangerous, and it happens very, very quickly. So I would be very cautious of that. We're going to transition here in just a little bit. I know Joe has maybe one more question, but I want to just let our listeners know that we're going to be, he has some tickets here for the Good Life Festival at Encantera Country Club this weekend. And I'm going to let Joe tell us a little bit about it, but I'd like to do a little raffle or call in. So, when he gets off the phone here, we'll probably take the fifth caller. So those of you listening, call in 480-745-1033. He has a couple tickets for this weekend, and it really looks like a great event. So we'll get to that in just a minute here. Are you there, Joe?
I'm here.
Okay.
That is going to be a great event. That's the Food Network's event. They're coming out to Encantera, and a lot of those famous chefs on TV and some people from the guy that does the those exotic cakes. It's going to be really neat. They're going to have wine tasting.
Really?
They're going to be cooking all kinds of different types of foods. And then maybe you can ask them some food questions as well on preparation. Who knows? But let's give away a pair of those out to Encantera. We'll do it. We'll take the fifth caller right now, but I'm going to give you a question, and then I'll start taking some calls again. Let's see here. Nancy from Flagstaff would like to know, is starting a new weight loss regimen and wants to know, do you have a best way to recommend how to detox the kidney and liver?
That's a good question. There's a lot of different thoughts and schools of thoughts in terms of detox. From a medical, as an internal medicine physician, that's just not something that is incorporated in my practice, honestly. I do know that olive oil has been found to be a great modality that does help to kind of detoxify, particularly the gallbladder and some of the fats in the body. That's pretty much, I can't really tell you exactly a specific regimen at this point. That's just not part of my practice pattern.
And I want to add to the olive oil thing. Since I changed my diet of eating butter, I don't eat butter anymore. We eat olive oil. I'll tell you what, it is just, this morning, all I had was 2 scrambled eggs with olive oil. That was it. and they taste better. They taste fantastic.
You know, we need to think, we're just talking about weight loss and you know, starting a weight loss program and those kinds of things. I think if we start thinking about, instead of keeping foods away from our body, to really start thinking about putting foods in the body that's healthy, that's beneficial, so that it's really about lifestyle changes and choices. For example, we know for sure that a lot of the green leafy vegetables, kale, broccoli, these have great potential health benefit to the body. So instead of, you know, eliminating and acting from a place of scarcity and diet, to really start thinking about what can I bring into my body that's going to make it more healthy. Start choosing, for example, fruits and vegetables instead of potato chips and Doritos, you know, those kinds of things. Maybe fish and meat, or fish and chicken instead of red meat. You know, those kinds of things. To use, as Joe was just saying, olive oil, which is a very, very healthy, beneficial fat. It's a polyunsaturated fat that you know, that we can eat. And not only, you know, is it something that we can cook with, but it actually brings value to our health. It actually helps to kind of flush through the arteries in the body. And so people who, for example, cardiologists, you know, swear by increasing the polyunsaturated fat in the diet, and people who have coronary artery disease or cardiovascular disease, because it really helps with, you know, decreasing the incidence of plaque formation and so forth. So there's a lot of beneficial things that can be done when we eat. We have a winner for the ticket.
We do. Okay.
Perry Winkler from Gilbert just won a pair of tickets for the food festival this week.
That's right, and it's going to be a great time. Make sure, I'm going to be out there too. Make sure if you see me, stop by and say hello, and absolutely would love to say hello and maybe get a picture with you.
That would be great. That would
Perfect.
Be good. I want to kind of transition now, Joe. Do you have any other questions or anything before we move to
we're good right now.
Introducing Sean? We have a guest in the studio today, and I want to introduce Sean Phelan, who actually is the president and CEO of Senior Helpers. You know, and I got to tell you, before the show we were talking, and just listening to what these guys are doing is really, I think, a huge asset to the whole continuum of medical care. You know, as a hospitalist, people out there know that my practice is predominantly in the hospital. We take care of patients that come into the hospital, and you know, we discharge, plan, and really ideally try to get people home, as opposed to nursing homes and those kinds of things. And what we were talking about, Senior Helpers is really a program where they really go out to the home to help people that need help in the home and be able to stay in their home longer. Sean, I want to introduce you. Thank you for coming today.
Thank you, Dr. Borik, for having me.
Why don't you just kind of give us a little information about Senior Helpers, what it is, you know, and how long you guys have been around and all of that.
Yeah, I opened up the Scottsdale East Valley office in 2007, so we are through 6 years.
Wow.
Simply put, Senior Helpers helps seniors stay at home independently. And we do that with 2 different types of services. We have a homemaking service, and we have a personal assistance. Homemaking is hands-off, meal preparation, light housekeeping. It can be running errands, it can be doctor's appointments, it can be medication reminders. The personal assistance gets more involved with the ADLs. It's hands-on, bathroom activities, dressing, grooming, transfers if needed. And so it's those 2 basic services that really help the seniors stay at home longer, improves quality of life, and for me, it's about aging with dignity.
Absolutely. You know, I'm just thinking about patients that I have that I can't tell you how many times on discharge planning, you know, a patient comes in and, you know, their family may be out of state and you know, they're here, there's nobody to help them, you know, they don't meet criteria to go into a skilled nursing facility, and so the best that we really can do is maybe to send them home with home health, but that's just a short period of time.
Yes.
This seems like this is something that really could be more of a long-term relationship.
Absolutely. We work actually alongside home health, and we will continue on after home health stops. Phoenix is a great retirement community, so there are a lot of seniors here where family is out of state. So, and we work with the families out of state. I have a Keep You in the Loop program, which we will, every week, we will report back to the family members via email or a phone call, and just let them know how mom and dad are doing.
That's really fantastic. I'm going to break. There's a question, Joe?
Yeah, Melvin from Florence Gardens wanted to know, do you do injections for patients that need them when you're taking care of them?
Caregivers can do medication reminders, which basically is it's time to take your meds. Typically, family members will manage medications, and that's ordering and putting them out in the pill boxes. However, I do have an RN on staff that can do medication management, order prescriptions, lay them out, and provide those type of injections if needed. It's an extra cost,
right,
but we do have an RN on staff that can do it for family members that need it.
So we were just talking about Lovenox. Let's say I have a patient that has a blood clot that we're sending home, starting Coumadin, but it takes time to build Coumadin up. And, you know, Lovenox is something that bridges the gap, and it's an injection. A lot of times people don't want it or don't feel comfortable doing that. Is this something that your staff or your nurse would be able to do, would be like a Lovenox subcutaneous injection?
Yes, yes. The caregivers cannot. Liability-wise, we're not allowed to administer medications, so the caregivers have to stop short of it's time to take our meds.
Right.
But the RN does kind of bridge that gap for us and is able to provide those medications if needed.
Wow, that's great. So we were talking about an assessment or a care plan. Kind of go through what that is. How do you assess? What is your assessment?
Well, typically I will come out and visit with the family, meet the senior in question, and kind of just go over the program and really ask a lot of questions. You know, and we go through all the ADLs. You know, the ambulation, the bathing. If transfers are needed, you know, eating, cooking, dressing, grooming, toileting, all those things. We want a detailed list of everything they can do and what they can't do. And then it's really kind of schedule driven. Our best client is where family's involved, and we kind of fill in the gaps where they need to either go to work or attend to their own family. They know, peace of mind, someone's there looking after mom and dad. So the assessment process probably takes about an hour, and then from there we will assign who we think is a good personality fit with from a caregiver standpoint, and then, you know, they're kind of off. We offer a 2-week trial period, so there's no long-term commitments. Families can try it out, see how they like it. And more often than not, it's a good fit, and they continue on. And
you said that, you know, sometimes you do like post-op. If somebody, you know, has a hip surgery or just, you know, post-operatively, you can go in for that short period of time.
Yep.
Or respite.
Absolutely. Yep. We do. You know, we've got many families on long-term care with us, but we do a lot of post-op. We have snowbirds that come in that call us each year. Because they know they're coming in, they're going to need some help. Post-op can go from 2 weeks to 2 months, and, you know, we'll work alongside PT. If PT's coming into home to help them after the post-operation, our caregivers will continue with PT afterwards. So we want our clients moving. We want them up. We want them doing their exercises, and we want to get them back to 100% as quickly as possible.
Now, do you come every day, or do you stay overnight? I mean, what is the availability?
We can come every day. We've got many families that we're with 24/7, as a matter of fact, and we've got live-in caregivers. The majority of our clients are hourly. We can come as little as 4 hours a day, twice a week. And but we have some clients that we're with every day. And again, it goes back to kind of those filling in the gaps where it's needed. If family's involved, it makes really good financial sense for the seniors, because there's always someone looking out. You know, when the families that are here or the seniors that are here without families, you know, we have the staff that's available for them 24/7.
Boy, that's great. How would somebody get in touch with you? You
know, we've got our phone number here locally is 480-621-6672. Seniorhelpers.com. We'll get you to just put in the zip code in the valley here. We're primarily East Valley, Scottsdale East Valley. So we go as far south as Sun Lakes and as far north as Carefree. So all they got to do is plug in a zip code, and our office will pop up.
Now, are you anywhere else other than in Arizona?
We're nationwide.
Really?
Senior Helpers started in 2001. We've got close to 300 offices nationwide.
Wow.
We've got a Sun City office on the west side, and we've got a Tucson office right now. And I cover, obviously, the East Valley. So we're growing. It's a growing need. It
really is. You know, there's studies now. There was just a study out talking about baby boomers, you know, living longer than their parents, but less healthy. You know, and I think as we age, I mean, as we see the population aging, you know, the baby boomers are taking care of their parents, and I mean, there's that whole need, I think, for something like this. And I think everybody's really in agreement with, we want to keep people at home. You know, when I send patients out of the hospital, the last thing I want to do is send them to a place that is not known to them or that's foreign. If we can try to keep them in their own home, that's ideal.
Absolutely.
And it sounds like this would be a great way to help do that.
It is. It's a great way for seniors to maintain their quality of life. As I mentioned earlier, it's about aging with dignity. Everybody wants to age in place. Nobody wants to move. And so it's a great service to enable those seniors to stay home as long as possible.
Let's talk about movement, because exercise is so important. We were talking about that a little
Absolutely.
earlier.
It's a big thing for me as well. I'm very health conscious, and one of the things that I try to do to differentiate ourselves from all of our competitors here in the Valley is we really encourage seniors to renew their attitude about exercise, healthy eating, and mental stability. And we do that by incorporating an activity plan into every care plan that we draw up for the families. And it's about getting them out, getting moving. Motion is lotion. We want them engaged in the community. There's a lot of fun stuff. My staff scours the internet for free things to do. Mesa Arts Center offers free concerts in the park during the winter season at noon. And so those are fun, free things to do. Get out, stay engaged. We look at diet. If more fiber is needed, home cooking. All our caregivers cook. For some of our clients that are experiencing, maybe dementia or Alzheimer's, we have many cognitive activities that we can do. There's no cure for it, but we can slow it down by keeping them sharp and staying on top of those things.
Right, absolutely. Joe, any comments or questions? Just talking about slowing it down and just your motion, there was a study out that I had referenced just recently about Parkinson's and people with Parkinson's disease. A new study out shows that, the bicycle, the stationary bicycle, just the use of that bicycle and increasing the speed of the pedal has been found to link and actually slow the progression of Parkinson's in the substantia nigra, which is a part of the brain. And so little things like that,
absolutely,
would be a great added benefit that these people can benefit from, from you guys coming in.
Yep.
Question.
Is this a service, or is this a self-pay, or is it covered by insurance?
It's primarily private pay. However, if seniors have a long-term care insurance policy, that will reimburse them for our services. Medicare and health insurance, unfortunately, has not recognized our services yet. Hopefully, they will with the cloud of the 30-day readmit over hospitals right now. They will recognize that home care is a lot cheaper than hospital care, but right now it's private pay and long-term care insurance.
Somebody out there asked, did I understand correctly, or is it a minimum of 4 hours per encounter?
4 hours per encounter.
That's the minimum, is that right?
That's the minimum.
Okay. So what would something like that cost?
Prices range from $20 to $25 an hour. It's very reasonable. It really kind of depends, and the assessment really tells me which service to offer. The personal assistants tend to be more mid to high range. The homemaking services tend to be more mid to low range. And it really depends on how often we're coming, how long we're staying. We can go 4 hours, we can go 24 hours. So.
Right. That's really interesting. I mean, it's a great gap to fill for people that that need help. Do you work with hospice at all, or is that not?
We do, yeah. We work very closely with hospice. Hospice is a tremendous service for the families. They will do a lot of the medical care that's needed, the bathing that's actually done, and we will come in and provide respite to the family so they can get out and do what they need to do, and we'll stay with the senior right along hospice if they happen to be there, but after they leave, which they're only there for typically an hour or two.
Right.
And sometimes there's a bigger break that's needed. So.
Mainly in the home. So people
Absolutely.
that are being followed hospice at home. And I think that's important for the listeners to understand, is that when somebody goes home with hospice isn't there 24 hours.
No, absolutely not.
Right.
And even when they're in an intake unit, staff, they're not staffed to look after each patient individually. So we've had families that brought us into the intake units and have stayed with their seniors or their loved ones while they're in the intake unit, and then after they come home.
Right. I think that's huge. That's great.
Do you have? This is from Trina in Mesa. Do you have a service to where, I guess Trina and Trina's husband, they travel a lot, have an elderly family member. Do you have something to where you guys can, if they brought that person with them, you could go along and take care of them during that time? Or can somebody stay at the house for 2 weeks at a time?
Yep. Yep,
Okay.
That's absolutely part of our program. We've had some of our seniors go up north in the summertime, and the caregiver goes with. Sometimes families leave for vacation, and then we'll come in and watch over them while they're gone.
Right. That's great. That's respite. I mean, isn't that
That's
really what we mean by respite?
Yeah, respite is we're providing care for the senior, but we're providing respite for the primary caregiver, which tends to be the eldest child or the husband or wife, depending on which one is experiencing the difficulty.
What does respite mean?
It's providing relief. I guess the best word is relief from stressful situations. So respite
for the
care
caregiver,
for
right.
the caregiver,
Gotcha.
exactly.
Right. We've had situations where family members would drop their loved one off in the ER, and have to go on vacation, and they would just basically leave them there, and it's like, well, if we don't really have anything to admit them into the hospital for, what do we do here in this situation? That happens, and that's a reality.
I've heard those scenarios.
Yeah, and so
Wow.
So that's where this would really be a
Absolutely.
beneficial. It has to do with cost, I'm sure, and
Sure.
and insurance, but I think it's worth it to to have the peace of mind to know that you're there.
Yeah, I would say most of our clients fall into the range of probably under 30 hours a week, because that kind of makes financial sense as seniors start to progress with whatever health issues they have. Maybe it's dementia or just worsening health overall, and they get into the 40, the 50, the 60 hours. Families tend to look at, okay, we're spending this much here. What can we get at a community
Right.
for the same bang for the buck?
Exactly.
We have some families that mom and dad are staying home, and that's it. They do not want to leave, and we can handle that as well too.
So how many people is in your employed in your company?
Right now we've got about 55 caregivers on staff.
Local here.
Locally here, yep. And like I said, they range from the 4-hour visitors to the live-in.
Right. Sean, what would it
caregivers.
cost? Let's say somebody wanted you to come in and stay overnight. What is the overnight fee, or how does that work?
Yeah, for a live-in, and if the senior qualifies, obviously they have to sleep through the night, because our caregiver that's there is there tending to them. But if they're up 4 or 5 times a night and then they have to care all day long, that's not a healthy situation. It's a dangerous situation. So if they're able to sleep through the night, it's a flat rate of $300. If you're looking at hourly, that's well over $400 on an hourly basis. So we try to help the families out by cutting that back, knowing that the caregiver is going to have a good 6 to 8 hours of rest.
Right.
Still within an earshot of the senior if needed. And in some cases it's a monitor, if it's a bell that they're needed, that they can react and be there if they need to get up and use the restroom or whatever it is.
Right. That's good. It's really it's a great concept, I think. Especially you refer to the 30-day readmit. Those of you listening, the hospital is really being scrutinized now in terms of patients that are Medicare patients that are discharged from the hospital, and within 30 days, if they're readmitted into the hospital, that's not going to be covered. The hospital's not going to be paid for that. And so, we've got to be really aggressive and cognizant of, managing these patients and not discharging them too soon, making sure that, that everything is in place, and making sure that discharge planning starts from the day that they come into the hospital. And as a hospitalist, that's really what my job is to really manage that patient, orchestrate the care of the patient in the hospital. And on day one, I'm thinking about, well, how am I going to discharge this patient? And so, these are the kinds of things that we need to start thinking about.
Absolutely.
Because if they don't meet criteria for a skilled nursing facility, and we send them home, we know that they may bounce right back if they don't have the resources. This might be a perfect avenue for that.
Yeah, and we've been able to partner with hospitals in the Valley now because of our transition program. We've got a hospital-to-home transition program.
Excellent.
Well, where I will bring in my RN and do a free assessment. And then we work with the hospital, the discharge case managers. If DMEs are needed in the home, grab bars, ramps.
Durable medical equipment.
Yep. Seats, special seats for shower chairs and stuff like that. We'll coordinate all that, so that's all set. The house is ready to go when they're home, and so our goal is to make sure that they're not readmitted in that 30 days. Obviously longer too, but we want to set the table to make sure that they're going into a very safe environment.
Right. That's great. Joe, do you have a question?
Yeah, Red from Surprise would like to know, is this a franchise or privately owned company? And he says, how are we assured the caregivers are really qualified in your operation?
Great question. It is a franchise. And I carry a $1 million policy. All my caregivers are bonded and insured. I think probably the most important job function in our office is recruiting and screening. I want the best caregivers, no doubt. We do background checks. We do drug testing. I run TB tests because we do work at some of the facilities. I run a DMV report. They have to have a good car and a clean license. I Google their name. We call on previous employment, and we call personal references. Everything needs to check out or they're disqualified. Even after all that's said and done, what I'm really looking for is the heart behind the qualification. And the $1 million question is, would I want you looking after one of my family members?
Right.
Once that's all done, they are eligible after they've taken 2 initial training courses with us. They are eligible for their first assignment. It's not easy to get employed with senior helpers, and we want it to be that way.
Absolutely. Now, RNs, LPNs, what is the?
Certified nursing assistants, CNAs, licensed caregivers, and companions. They have to have a minimum of 3 years experience. It doesn't have to be paid experience. It could be caring for a family member. I want
Right.
caring, compassionate caregivers, and caring for a family member speaks volumes about a person.
That's huge. I mean, that really, really is great. I invite you, if you're listening, we know the end of the show here, we have about 10 minutes or so. I want you to call in if you have any questions. This is a great opportunity to talk to Sean Phelan, the President CEO of Senior Helpers, 480-745-1033. Anything else, Sean, that you want to kind of just tell us about in terms of, how did this come up? What made you think of this whole? Is this just a franchise that you connected with, or what was your interest, and why did you become interested in something like
Well,
this?
interesting enough, I met the owner, and it was actually coming off a personal experience of myself with my grandfather. We ended up pulling him out of the home, moving him in with my mom. And it got too much for her. His dementia, he was starting to wander. He would wander out of the house when she was gone, and she'd come home and he was gone. And so she'd be searching the neighborhood for my grandfather. And it just really got too much. So the next move for him was, a facility, and it was the hardest conversation we ever had to have with Grandpa, is tell him that we had to send him away. And shortly after that, I got introduced to Senior Helpers, and I was like, wow, I wish we would have had this, back with my grandfather.
That's huge. I mean, that testimony really speaks volumes to what this is really about. Joe, you have a question there?
Stacy from Mesa would like to know, I guess Stacy, she kind of briefly explained it, has been looking for 2 weeks for her mother, who is elderly and apparently had not your company, a different company, and found out that their caregivers, even though they drug test, were fine as long as they had a state card, a marijuana card, and says, I am not happy with that. I have moral and religious issues with that. Do you allow your caregivers, if they have a marijuana card, to work for you?
That's something that we have not had to deal with just yet, but it's brand new in Arizona, and corporate, I know, is looking at it. Obviously drinking is legal, and we don't allow caregivers to drink before they go on the job.
Right.
So, we have to obviously approach that delicately, but we do not have right now any caregivers on staff with their marijuana card.
That's an interesting question.
It is an interesting question, and personally, I'm not a fan of it, but because it's legal, you have to look at it the same way you would drinking. Obviously, we don't want drinking before an assignment, so that would be the same rules I think would apply.
Yeah, that's just to me, that's not something that is acceptable in terms of healthcare.
Right.
You want to make sure that you're on, that you're focused, that you have all of your faculties, when you're
absolutely.
making decisions for other people and their health and safety.
A question off the chat: do you offer assistance with errands or going to medical appointments?
Yes, we do. That's part of our homemaking service, and also, and with our personal assistants, you get all the homemaking services that come with that. So it's kind of, once you're in personal, you get everything.
Okay, so kind of go over that again. Like if somebody were interested in you, helping them go to doctor's appointments and so forth, what does that look like when you say they get everything?
Well, if if they're on our personal assistance, which is the hands-on service with
right.
the ADLs, transferring, bathing, toileting,
Right.
you know, that sort of thing.
That's one thing.
Yeah, we will handle all the homemaking services
Okay.
as well. So if they need doctor's appointments, we'll take them to doctor's appointments.
What if they only need the homemaking?
Then no problem.
Okay.
That's you know, also a separate service. It's typically, we don't assign a CNA to homemaking because it's not needed. So we'll assign a caregiver or a licensed caregiver.
Okay.
Our
So
licensed
that makes sense.
caregivers and CNAs tend to handle the personal assistance, where our caregivers will handle. Our companions, caregivers, will handle the homemaking
So if I had a
services.
patient that, let's say they had an appointment once a month, and they would be able to call you and have that homemaking assistance for that period of time as much as they need, or is it more of a long-term commitment? Or?
Yeah, we want to help everybody, and I certainly don't want to say no to anybody, but if I don't have caregivers that will work once a month,
Right.
so in those cases, what we try to do is what we call a piggyback assignment. If we have, you know, in Mesa Gilbert area and the Scottsdale area are probably our two biggest areas where we have lots of caregivers every single day. And so if we get clients that are in need for once a month, twice a month type stuff, and they're, you know, registered, they're signed up with us, and we've got caregivers in the area, as long as we've got enough lead time of knowing when that appointment is, we can usually kind of juggle and get a caregiver to kind of go maybe before her primary assignment or after her assignment.
That makes sense.
So
that's great.
We try to work with everybody as much as possible.
Sean, give us the number again, just in case somebody's interested in contacting you.
480-621-6672.
And do you have a website?
Sure, it's seniorhelpers.com.
Seniorhelpers.com. Great. And I'll make sure that we put this on our Facebook page, and those of you that are logged into DocTalk Radio, we'll make sure that they get that information.
Here's a good question that could slip between the cracks. Beth Rourke from Tempe would like to know, do your vehicles that you take patients around with for appointments have ramps or racks for those driving carts? How does it work if they're handicapped?
Okay. Most of our caregivers, well, all of our caregivers obviously have to drive and have good cars. A lot of our seniors have those vehicles and prefer to drive in their own vehicle. My caregivers are insured to drive the senior's vehicle. So, no, they don't have the necessary equipment on because it's their personal car. But in most cases, we have plenty of seniors that just feel more comfortable driving in their own car. So we're insured to drive the senior's car.
Okay, so you can drive the senior's car if they have a ramp or if they have it. Otherwise, you don't have like a company, you know, van or anything like that. That would be like a van that you can hoist up a motor.
Nope,
chair or something like that.
We don't. We have partners in the valley, so we would probably need to get a hold of a medical transport company to assist them with that.
Okay, and that would be an extra cost, I would imagine.
Yes.
Yeah. Okay. I mean, that's a really, really good question. You know, some of those motorized scooters now, or the go-go, scooters. I mean, you can take them apart real easy and put them in the trunk, and it wouldn't be a major problem, I would imagine.
Yeah, I mean, we do that with
with
wheelchairs. Most of those break down flat. Walkers obviously break down flat. The girls know how to transfer from a wheelchair to a car seat, so that's not an issue. But the motorized, we haven't had a call for that.
Okay.
We haven't had a situation come up.
We got another great question. Rose from Scottsdale says, is there a minimum weight that your caregivers would have to pick up to be able to lift someone in case of a fall?
Yeah, well, obviously, if there's a fall, and the girls are trained on how to handle a fall properly. That is actually one of the first 2 training modules they need to take before they're eligible for their first assignment. So they are trained. Gait belts certainly help. If I do an assessment and I feel there is somebody that could pose a problem if they do fall, we will have a gait belt put in for the assignment. If for any reason they can't get them off the floor for any reason, company policy is call 911 and then to call the office.
And that would make sense.
We can get a second person over there to help them.
Right, that would make sense. CPR trained and all of that. That's a module?
Yep, they have to have CPR. Yep.
Okay, and I think that's good. You know, the automatic defibrillator, are they trained in being able to use that, or is that not?
You know, it's non-medical. It's a non-medical service.
Service, right.
Yeah, we stop short of, you know, all those medical things.
And I think that makes sense. You know, I think that's reasonable. You know, again, this is just bridging the gap. It's not intended to be a medical service, and that, you know, that's fine. That makes sense.
Absolutely.
Got another one here.
Good.
We got to run on interesting questions
Very
here.
great.
Raul from Mesa, do you cater to Hispanics with bilingual needs?
Absolutely.
Your caregivers, or do you have some that are bilingual?
We've got all kinds of caregivers. I would say most of them are female. It's a female-dominated industry. I do have male caregivers. I would say the bulk of them age 45 to 55. I have some younger. I have some older. We have all kinds of ethnicities, speak language. They have to speak good English, but we have plenty of caregivers that speak different languages. Yep. So yes, absolutely, yes, we cater to everybody.
You know, I was thinking, and this was something that just goes back to my training when I was a resident. We would take care of. I was involved in some diabetic teaching programs and so forth, and you know, we always recommend the diabetic diet. You know, the 1,800 calorie diabetic diet, and I thought, wouldn't it be neat to put together a recipe book that that really focuses on different foods from different countries that are geared toward the diabetic diet. You know, so you would have, you know, Greek food and Mediterranean food and, you know,
what a great idea.
Wasn't that a great idea?
That is.
You know, and so you said that you had people go into the home to cook. You know, let's say we had somebody from, well,
India.
Hispanic or India, you know, and their food is of that type.
Yep.
Would that be something?
Oh, absolutely, yeah.
You know, that you guys would be, you know, kind of open to do, or?
Oh, absolutely, yeah. I mean, we've got caregivers that are at all levels of cooking stages. You know, most of them feel pretty comfortable in the kitchen, but we do have some gourmet cooks. So,
you know, because I think that a big part of your clientele would be dementia, Alzheimer's dementia. Is that would that be accurate to say?
That is one of the big things that makes the phone ring nowadays. Besides the falling and loss of keys, they're not driving anymore. The dementia has come on pretty strong, and we launched a brand new program. It's called GEMS, our GEMS Senior Helpers GEMS program, and it's pretty intensive training for the caregivers, but it's been really received well in the community because it really helps the seniors in dealing with this journey that they're going on, this disease that there's no cure for. And we're launching a part 2 right now where we're training the families now to understand what their loved one is going through so they can better understand and cope with it.
You had shared with me an example about a patient encounter. Do you want to just share it with our listeners?
Yeah, I'm going to, real quickly, the GEMS program, the inspiration behind the GEMS program was that every gem has value, and so we feel that every senior going through this disease has value, and so the different gems are for the different stages of the dementia and Alzheimer's. And one of the things that the caregivers are taught, you know, the basics is, you know, don't argue, but deflect and redirect. And we had a great case that came up where a senior or one of our caregivers came over for her assignment, and she saw some luggage at the door. And she asked her, the senior, well, what are you doing? And she says, oh, I'm going home. And with people who don't know what Alzheimer's is about, it first starts to eat away at your short-term memory, and then it starts to work backwards. So the house that she lived in for 30 years was no longer her home. Her dementia had progressed to where her childhood home was the home that she was thinking of. So the caregiver knew exactly what to do, not to argue. She said, well, we can't travel on an empty stomach. Let's go have breakfast. So, of course, she agreed. She served her breakfast, got her all taken care of, put the luggage away, and there was nothing ever mentioned about it. Yeah. So that's the benefits of training. It empowers our caregivers to feel very confident that they can handle those situations.
Very powerful. Yeah, that's, I mean, that's great information. Deflect and redirect?
Deflect and redirect.
Direct and and that's good. That would be good for anybody.
Yeah, absolutely. But, you know, they're taught on how to verbally approach dementia and Alzheimer's, how to physically approach, you know, to respect the space, how to touch and not to threaten. It's very threatening.
Sure.
As the dementia and Alzheimer's progresses, vision comes in, you lose your peripheral, so the vision starts coming. So anything from the side can be, scared.
Starting.
Anything straight on can be. So you really, and it's a really intensive training. We actually bring the caregivers in the office for that because it's a full day of training.
Nice.
There is refresher courses in each of the modules. As if an assignment is, if we have a client that needs gem care, the caregivers are required to do a refresher course before the assignment starts. So we're on it, and it's a big deal right now in the community and the calls that we're getting for it.
Excellent. Very, very good. Well, the show, we're just about out of time. This hour went really, really fast. Sean, I want to thank you for being here.
Thanks for having me.
Really great information. Joe, that's it for today. We have our winner, Perry Winkler from Gilbert, so we'll make sure you have the information to get these tickets out to him.
Absolutely.
And we'll see you next week. Thanks for joining. This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.